Welcome, everyone. I think we're going to go ahead and get started. I'm happy to present Dr. John Elder, who's from San Diego State University. Dr. Elder has been a member of our Scientific Advisory Council since its inception, and a friend and colleague for a long time. He was on Catch with us back in the day, so that's when we first got introduced. So it's been, I guess, several decades now. But yeah, so back even farther.
Cheryl and I go back to 1980.
Yeah. So even though he's a Nebraska fan, we welcome him to UT because he does have a daughter with a degree from UT, so he's got to claim some allegiance here. So without further ado, I'd like to turn it over to Dr. Elder, and he's going to present on agents of change. And so this is really great. This is from a meeting he was at prior to coming here. So we're getting it very timely manner. So, John?
Great. Thanks, Dan. Okay, so get this clipped on. The sound okay? Okay, anyway, ready to roll. All right, agents of change. We're going to be talking about health communication that's mediated through usually paraprofessionals, volunteers, or through professionals not necessarily trained in a specific area, not highly educated PhDs, MDs, etc., but just normal people. So this is prompted by a conference I gave a keynote at 2 days ago, but I tried to develop the slideshow, the presentation, much more broadly. So I want to give you kind of my historical perspective on agents of change, and talk about some ways it might fit into all the great work you all are doing here, and maybe some future directions that all of us need to be thinking about. So anyway, there it is. That's me, and February 10th is today. Okay, so we're talking again about interpersonal communication in a McGuire sense with the inputs, communication. One of his inputs is channel. So if we think about channels of communication, most people will think about something in mass media or social media, but I also think of interpersonal communication as an important channel. In fact, it's the most fundamental, most human channel, and arguably the most impactful channel of any of the potential ones. Okay, so why do we use interpersonal communication? Well, it allows a person to give information, to present the pros and cons of various health behaviors or health actions, and at the same time, the individual presenting the communication, the change agent, can listen to and see what the participant, or what the patient, what the community member, what the student is doing, and respond real time to that participant. So it's really important, I think, and it's far more useful in that sense than would be mass media, which tends to be unilateral, or even social media, which is bilateral but not necessarily real time, and certainly not with the ability to read body language, to read context, and all of those things. The other thing with frequently, not always, but frequently, we're talking about community health advisors or volunteers who have day-to-day contact with the recipient of the message. So it's somebody who's in that person's environment. Maybe it's a neighbor, a family member, or a gatekeeper, but someone down the street. It's someone who is seen by the audience on a frequent basis. And so even if they don't engage in a conversation about that health topic, they are able to be reminded that they should be thinking about a specific health topic. So you're not going to, if you've got a community health advisor trying to help you quit smoking, probably not a great idea to light up in front of that community health advisor. Not that they're going to put you in jail or anything, but you just feel like, whoa. Anyway, it is a prompt. It can be a positive reinforcer and a negative reinforcer, whatever. But it is an important visual prompt and social prompt for a person to continue with a health behavior change effort. This technique is very broadly adaptable to across cultures, across nationalities, across economic classes. And I will be showing some domestic as well as international examples in ways that we might not typically think of. But it's not just about childhood obesity. It's not just about tobacco control. It's not just about our usual suspects in the domestic agenda of the United States of America, but for just a wide variety of different applications, whereas social media would have less of that potential. Mass media in some formats would be more constrained, but interpersonal communication is, of course, always there. Okay, who are these people? Well, they're sometimes participants in a particular effort. So they might be people who are actually trying to make a change themselves, or in Ev Rogers' sense, it might be an early adopter within a community whom you identify through some formative research, through some qualitative research. But often they're people who are part of the target audience. It could be traditional healers in developing countries, especially, or traditional societies, where there are often there are parallel health systems, if you will, with the formal health system having a kind of a Western flair, doctors and nurses and whatnot. But also a more traditional curandera or other type of person who may be a source of health information for a lot of people. Not always the kind of health information we want them to give, but it is the tradition in many cases. A lot of work we do in San Diego in the Mexican immigrant and Mexican American community, we call them lay volunteers. We kind of comb the neighborhood to see if people would like to volunteer. We often pay per diem. We usually, of course, pay per diem, sometimes a stipend, always cover expenses, of course, and mileage. But generally speaking, these are volunteers who maybe have had some experience volunteering in the past, maybe are trying to work toward a junior college credential, any variety of things. But usually it's a lay person or someone who's not highly educated. Sometimes opinion leaders as well. We will, in qualitative research, find out who people reach out to for health information or for general information about resource needs that they may have, or about the driver's license process in San Diego, or welfare, or any variety of things. Find out who these folks are, and then we'll try to contact them ourselves and say, would you like to participate in this project? Here's what we got to offer, but you come highly recommended. And sometimes a lot of projects I've done, you'll see two examples. We will use paraprofessionals, people who maybe are physician's assistants or nurses aides or health technicians or students. I'm in a university with on nearly 30,000 undergraduates. Believe me, we're aware of that resource, and we do take advantage of that resource. And they in turn get college credit and real life experience in some of our projects. I think the cutoff point, at least in this somewhat retrofitted chain of research I'm going to present, is that the theme is that these are not people who are formally trained to perform a given task, carry out a certain responsibility. These are people who may be professionals, but may be in a different discipline, or they may be students who haven't finished their training, or they may simply be volunteers. Generally speaking, of course, we try to look for leadership, compassion, familiarity with the community. Those are all important features. And some of these things we have to screen for. We actually have role plays where, for volunteers especially, we want to see that they're able to lead a group, that they're able to listen, give reflective feedback, not make things up, those sorts of skills and attributes. So what we're trying to do is give people in-depth exposure to communication. I'll get back to this from a public health perspective a little later in the talk, but rather than looking at just mass exposure to a brief message, a 15-second television spot or a Super Bowl ad for those of us who can afford that, or a radio spot or something that we just drop on some social media advertisement. What we're trying to do instead with community health advisors is give in-depth exposure and then real-time feedback about that issue. So it's a smaller reach in many cases, but a much higher frequency and a much longer exposure. What we try to do is clear up misunderstanding. We want to make sure people truly understand what a physician has told them. You see a lot of patient health navigator systems now being set up. Really trying to make sure that the patient and the doctor are communicating, because the patient will almost always say, yes, I understand. Very seldom ask the doctor to repeat something, or if so, the second time they don't understand it, they're going to say they understand it. So there's a lot of elements there. People are ill at ease in provider communication in a medical setting. They want to get out of there. The physician may have or the nurse may have a lot of things to say in a short period of time. And so what we're trying to do is make sure that these complex practices are understood. Sometimes that can come back and bite you, because we've had, of course, volunteers who, when in doubt, will make something up, and so it actually increases the misunderstanding. But generally speaking, that is the goal. Okay, so I'm going to give you some examples of the work I've done over many years, even before I knew Cheryl. And the first is from my first job as a postdoctoral job in southern West Virginia. I was a clinical director of a large federally qualified mental health center in a 4-county area in, you can see a little town in the south central part called Beckley. It was in that area down there. So this is a region in the United States marked by extraordinary beauty, both cultural and geographic, and there's horrible poverty as well. So it was a real challenge to work in these areas, and the use of typical communication was almost impossible. Radio reach was nearly nothing. Television, low access even in those days. What was part of my task was to figure out what we should be trying to improve, how we should try to improve our services. And again, this is a 4-county mental health center, 2 very small centers, and 2 fairly large counties as well. And so what I looked at in those days, in the late 70s, early 70s even it began, was systems dependence. That was the hot topic. And what we were trying to do was get psychiatric patients to be able to survive and thrive in the community and not depend on the mental health system, except to get them through crises. Or in the case of chronically impaired patients who carried a diagnosis, say, of schizophrenia or something like that, to maintain them, keep them out of the hospital, because psychiatric hospitals were losing all their resources and getting closed down. So we looked at the systems dependence model and found that with the severely impaired clients who had a developmental delay or schizophrenia type of diagnosis, we found our services were doing pretty well. We were not recycling many patients to the hospital. But then I looked at the service that we were providing to outpatient patients, people who presented with anxiety, depression. This was adult services. And things that generally, through behavior therapy and through other techniques that did not involve medication, my staff were simply referring them to a psychiatrist. And 100% of the referrals to a psychiatrist resulted in medication. And seldom, once they were on medication, did they ever get off. And we had psychiatrists who were winning free trips to the Caribbean and free cruises because they were setting records for a number of prescriptions that they were writing. Seriously. And I thought, well, that doesn't work with me. And so I looked at ways to do something about this. Now, why is this an agent of change? Most of my staff, I had 45 or so counselors working for me, but almost all of them were bachelor's level. They weren't really trained, and they could have been in history or English literature or whatever. They weren't really trained to do this sort of work. Or their master's level, and they were simply, it was ingrained in them to refer to the psychiatrist. So what I did was I developed a system where trained them in depth on how to manage anxiety without medication and non-psychotropic ways to manage depression. Those are two things that were proven that could be done. It was in the literature. It was verified. So I went around, gave workshops, intensive 2-day-long workshops in these various techniques to keep patients, to manage patients other than through drugs. And then just to make sure that their hearts as well as their minds were following me, the counselors could still refer to a psychiatrist instead of going through these behavior therapy techniques, but they had to do a lot of extra paperwork to do that. So I added 2 or 3 pages of explanation they had to go through to be allowed to refer to a psychiatrist if they had not tried these techniques first. So anyway, a combination of carrot and stick. So here's what happened. I did this in a multiple baseline design. This is a great design, by the way, for those of you who are working in real community settings when you cannot randomize schools, you just don't have enough of them, or you don't have the resources to do that kind of study. You cannot randomize clinics, you cannot randomize cities. Think of time series designs that will still allow you to show an experimental effect. So I state that kind of as a tangent, but this is a great real-world design. Time series, staggered time series design. Anyway, it's the advanced part of Campbell and Stanley. They use different terminology, but that's it. So here we see the percent of patients who left admissions with medication, and we got nice little drops, especially in the first and largest clinic, and we kind of tracked it all the way to wiping out that practice in the bottom 2 clinics that were combined in the very small counties. So anyway, it worked. We got these people to practice the Control Your Depression, Peter Lewinson's book, fantastic book, and various deep muscle relaxation, other relaxation, anti-anxiety techniques. So, taking that, and then I didn't want to do that job. I mean, that was effective, it worked, but it wasn't really what I wanted to do with my life. So I found a job in Pawtucket Heart Health Program, which was a spin-off project funded by NHLBI from the Stanford Heart Disease Prevention Program, 5-city program. And that's when I met Cheryl. And so I took a job in Pawtucket, Rhode Island, which is old mill town, steel mill and factory town on the Rhode Island, Massachusetts border. These are tiny places. Rhode Island is probably about the size of Travis County, I would guess. But in any case, this was the theme of Pawtucket Heart Health Program, set up by Tom Laster, my boss, was that we would accomplish this through volunteers, through community health advisors. We would lower risk for heart disease in an entire city. So we did a pilot project at Texas Instruments, which is a factory in Attleboro, Massachusetts. And we got a bunch of people who were interested in losing weight in the factory. And we formed groups, and we chose our volunteers, our lay health advisors, through double endorsement. We'd send out a sheet, would you like to volunteer to lead this group, co-lead this group, because we'd have somebody else. And then secondly, who else in this group would you recommend? So by combining those two things in a very simple sociometric, we got the people we wanted to run this weight loss group. And we contrasted that with groups led by industrial worksite nurses who were professionally trained, knew the techniques, knew the lingo, and all of that. Good weight loss at 28 weeks was a fairly short follow-up, but pretty good weight loss at that period of time. But no difference between the groups. The community health advisor group lost a little bit less, but not significantly less than the nurse-led groups. However, it was much less expensive. We had to pay for nurses' time, and that was not cheap, and we had to take them out of their other job, make sure that was covered. So the cost per kilo was much lower in the community health advisor group. But we weren't able to take it to scale. We tried doing this then on a mass scale, moving just a few miles south into Pawtucket, a city of 70,000 people, and trying to find all these organizations, churches and work sites and schools, etc., was just kind of fell apart on us. It was way too much of a challenge. So, 2 examples, and I want you to think about some of it, just how you rate the ultimate impact of what we do, and some of the work you all do here at the Dell Center. How do you think about this retrospectively? How well did it do? Well, in terms of training effort, the West Virginia effort was a lot. But it was part of my job. I had to do that anyway. So since I accepted it as part of my job, I wasn't trained. So the staff had to do in-service, and it was in there. The Pawtucket Heart Health Program, though, training was a huge burden on staff, and we were grant funded, and once we left, there wouldn't have been anybody to do this training. Efficacy, did it work in a real world situation? Or I'm sorry, did it work just in an ideal situation? Yes. Effectiveness, I think you can see in the West Virginia effort that it was effective as we rolled it out in a real world situation. Pawtucket, no, it was not. We switched back to what the other folks were doing at the end of a year or so. Effectiveness if backed by policy. Do you have to have policy change to make this happen? Well, more or less, I think. In West Virginia, we showed that some of the work we did was the carrot. We'd say, here's all these new skills you have, try them out. But then we put a little stick in there too. So without the official support for that, it wouldn't have happened. With Pawtucket, it didn't matter. There was nothing we could really do to make it to change policy. Scalability, more or less, somewhat, I think, in West Virginia, again, depending on the support. Pawtucket, definitely not. So this is the ultimate question for all the work we do with community health advisors, for Promotoras, for whatever efforts you're talking about, is does this really make sense in terms of a public health type of program? And so you see the contrast between these two different efforts in that sense. Okay, Project Shout. Students helping others understand tobacco, and this was modeled very carefully after the work that Cheryl and others were doing at Stanford even before I met in teaching 12-year-olds, adolescents, early adolescents, to refuse offers of tobacco and not start smoking because of peer pressure. So we tried a true peer program in Pawtucket and then in San Diego. This effort is from San Diego. But it didn't work because these kids didn't show up, or they forgot about it, or they had band practice that they had to attend, or something like that. So we weren't able to get 7th graders to help other 7th graders, but I was able to find a lot of San Diego State undergrads who were willing to do that. So replicable, but there are large universities everywhere, right? Throughout San Diego in 1988, I think we ended up in 12 schools, something like that. And junior high schools in those days, so beginning with 7th graders. Initially, we had designed it to do a 3-year program. It follows 7th graders all the way through the end of 9th grade. And that, looking at both cigarettes and smokeless tobacco refusals. It kind of fell apart on us, though, after the end of 8th grade, because then San Diego came in, where some schools went, or some districts went to a modified system of middle school, was 6th, 7th, and 8th grade, and then high school. So we had some of our students taking off on us and going to high school, and the junior high didn't exist anymore, and others in the traditional junior high school. So in 9th grade, we had to scramble and figure out what we were going to do to stay in touch with these kids. So we used undergrad. This is not San Diego. This is Tijuana, actually, where we ran a parallel study, the same thing. We took undergraduates, we trained them, and we sent them out to classroom to implement the refusal skill classrooms to implement the refusal skills training. So this was really interesting. We had 19, 20-year-old college students talking to 12, 13-year-old junior high school students, and they were able to communicate. And they also kind of got the ooh wow reaction from the junior high students, because they would see somebody who, they didn't see some old professor come in there, and that looks too much like their teacher anyway, but they saw somebody who they thought was like a big brother, big sister, and was kind of cool, and used swear words when they weren't supposed to, and all that sort of stuff. And ran them through these skills. And conversely, our students were able, I mean, they're not very old, they were able to think back just a few years and relate to these kids' experience. So that was somewhat fortuitous. We did it for logistical reasons, but we ended up with, I think, a better social connection than had we gone through teachers, certainly. Okay, so what do we do when we had to scramble? Well, we switched to a phone call intervention where we got these students' numbers. We couldn't do, even if we did find them, we couldn't do a high school intervention because a lot of the kids from the control group were going to the same high school. So we had to do something differently at that point. And so we ended up with newsletters, followed up, and said on the newsletter, we'll be giving you a call within the next week, 2 weeks, whatever it is, to check on it, see how things are going. Okay, so college age rather than peer leaders, so not peer in a pure sense, but kind of in between. 21 schools total in the study, 12 I think were in intervention. Okay, so the results were frankly some of the strongest in the smoking prevention literature. We got, in terms of long-term impact, I got terrific results. I don't want to sound Donald Trumpy here, but just incredible results. That were main, but I will. don't have the hair for it. But we don't. But we were able to track these students through 11th grade, and these results were sustained at that point. So, and these are verified through equalizer tests. Okay. So what do we get with Project Shop? Well, the training effort was still a lot. I mean, we had to train them. We had to go to the classrooms with them, kind of videotape them, listen to what they were doing. So it was a lot. I wouldn't diminish that. Efficacy, real-world situation, effectiveness, yes, both. If backed by policy, well, it's kind of hard to say. If you could develop work it into a say a health ed undergraduate curriculum or something like that, where this would be part of an ongoing assignment that students might have. But I do think that the college-age student was a key ingredient here. So it had to be in connection with a community college or with a university. And then scalability, some of the same issues there. Could we really go to scale? Could we make this a public health program? Well, then we'd have to find a place to house it. Department of Education was very happy to support it, but they weren't going to take it on. And they weren't going to put it in their budget, nor would the Department of Health. Whether it's truly scalable, I'm not sure. So again, we've got projects that are hard to figure out how we can go to scale with. And as you're thinking through the possibilities here, text messaging, electronic health records, other new avenues may help us in that regard. Yeah, Steve.
Just curious, I mean, you had great results on Shout. Are they doing in San Diego? You said the Department of Ed is one thing, but the school district's another.
We had one.
Local communities or local colleges.
One of our 5 school districts adopted it permanently. It became a permanent part of their curriculum, the Lemon Grove schools. But San Diego City Schools, no. It's one of the largest school districts in the United States, and they just wasn't in their bandwidth, I think, to do that. Yeah. The other thing is, frankly, in San Diego, the smoking prevalence is terribly high. So yeah, it was hard to argue from a priority perspective, I guess. Okay, Secretos de la Buena Vida, Secrets of the Good Life. This was a focus group. It was a low-fat, high-fiber nutrition promotion project. They chose Secrets of the Good Life through focus groups and things like that. I thought it was kind of hokey sounding, but you got to listen to your audience. Okay, 3 group randomized experiments, randomly assigned to off-the-shelf print, stuff that was already available from the National Cancer Institute, from ACS, from AHA, from others, and how and why to eat more fruit and vegetables and eat less red meat and fat stuff. Compared that to targeted and tailored print. We were still using print then. So we developed newsletters that used the family's name, specific name, and talked about their meals. Was all in our database. And so we would print out weekly newsletters every 2 weeks, depending, and it would have something that they could feel was somewhat addressed just to them, and certainly tailored to a Spanish-speaking community. It was delivered both in English and Spanish, but most of the participants were Spanish only. And then that was contrasted to targeted and tailored, plus Promotora delivered, community health advisor. So we had women who were from the neighborhood, had probably lived there a little longer, who were willing to go door to door with our participants and review the information in the newsletter. So the second and third conditions are the same, except the delivery mechanism, the middle one being U.S. mail, and the last one being somebody knocking on your door. Here we think about not a channel of communication in a McGuire sense, but a delivery mechanism. Just like social media is not a channel of communication necessarily, it's a delivery mechanism, because you can deliver print, you can deliver video, you can deliver photos, right? But you're doing it through a specific mechanism. Okay, so here's some of the off-the-shelf stuff. Eat less fat. This is from the National Cancer Institute. You can reduce your risk of suffering from certain types of cancer. Now, that's not really sexy, is it? And I'm not sure they had to go through many editions of this, but nevertheless, it's what people did. Promotoras, here are some of them actually from that project in action. One receiving her diploma on the right, a graduation ceremony, and the other doing a home visit where she brought the copies of the individual's materials and then some display information she had as well. Here's an example of how we tailored the newsletters. Simply in this, the cover page of the newsletter was the Serrano family has their own welcome kickoff newsletter with other information based in it. And then we looked at their most frequent foods. They were to choose from these various items, so we could print recipes and suggestions, cooking suggestions for them based on what they most commonly ate at their family meals. Typically, our promotoras in this case were not from the block or from the barrio, but a more middle-class neighborhood. They were more likely to speak English than the participants were, and they were more likely to be middle-class economic. One of the ways we did an intervention check on this was to have individuals go through a little homework exercise and then mail their homework back to us. So we gave them a pre-addressed, I hope we stamped the things. I don't know if we stamped. But if we didn't, that was a dumb mistake. Anyway, I think we stamped them. This one ain't stamped. But we had them mail it back to us then after they went through. Okay, here's an example of homework. How much does a certain item cost by weight and volume or whatever that is? So they had to go through it and calculate it, and then they were asked to send that postcard back to us. Okay, so we got a promotora effect at post-test around 12 weeks or so. That was the end of the intensive intervention. We did get a promotora effect. There was, according to 24-hour recalls, we got less fat consumption and more fiber consumption. But you could see why, perhaps, in terms of this process evaluation, because 30% of the promotora participants returned all 10 inserts, which is 3 times better than the other 2 groups. So having the promotora kind of remind them, maybe even sitting there and doing the homework with them and making sure they mailed it, was probably part of the impact of that group. And 14% of the participants in promotora group returned none of the inserts. In other words, checked out on that aspect of the intervention, versus 42% of the male-only participants. So of those 2 groups, you can see about a 3-to-1 difference in terms of that aspect of participation in the intervention. It's not dose response, folks. A lot of times I hear this over and over again, well, there's dose response. It really isn't. You can't self-select your dose in a dose response trial. But it does show that there's something going on more than just having the promotora doing more effective talks.
Did you call the male-only participants? Did they have any contact? Call them to remind them to turn back?
No. Nope. No prompts. Neither one. No. Neither of those comparison groups. So we got calorie change. Again, this 24-hour recall. So whether you want to believe these data or not, but they do favor at post-test, that's M2, that's immediately following the intensive intervention. They certainly favor the promotora group. Now, these women had average BMIs of 29, mean BMIs of 29. So Whether you want to believe this calorie consumption, it's daily calorie consumption or not, I'm not sure. But nevertheless, the pattern was in the expected direction. But notice then, once we stopped the home visits, and we just continued with measurement for equal periods of time of 4 months or 6 months, I believe, and then a year, how the impact changed, how the Promotora group totally reversed itself in terms of its favorable outcome compared to the other two. And while there was a strongly significant impact at M2 at post-test, the impact disappeared at M4. In fact, though it's not statistically significant, the control group started looking pretty good, and the male-only group was best.
So what's with the control group? They're going down the same way as the other two are.
Well, they did get information. They did get information, Bill. We did send them the same amount of information, only it was off the shelf. It was stuff we got from National Cancer Institute, from the local AHA. As long as it was Spanish language, they still got the information. So maybe they read through it, whatever, I don't know. But we did not measure that aspect of the process. I wish we would have. What you will notice, I hope, is that what we're missing here is a pure control group. And it makes me so sad that we didn't have that, because we could have made an summative statement then about the off-the-shelf group.
So you don't think that there's a dose there between controlled or off-the-shelf, tailored, and Promotora? You don't read that as a dose, more intensive dose in M2?
Absolutely. I definitely do, because Promotora is there every week, sitting down for 30 minutes to an hour, and making sure the woman, because they're all women, is engaged in the project and is engaged in the intervention. So yes, but without that external control, it might be that there was less generalizability, less sustainability.
So why did the impact disappear?
Well, I think they were doing it. There's a social desirability thing, and it's negative reinforcement in a Skinnerian sense. You're doing it because you feel some pressure to do that. You want to look good. You've got somebody knocking on your door who wants to see that you've been following the guidelines. And so when that person no longer comes to your house, glad that's over with. On to the next thing. But yes, we did. We did not get a BMI change. Pre and post was above 29. Yeah. No BMI change.
Were the other groups, the control and the tailored, were they from the same community? Like the same neighborhood? Is there any
Not the same.
possibility for contamination if like
We
knowing each other?
we stayed. I think we had about a 5-block barrier or something like that. So yes, there was possibility. We checked and just had a question. List all the people you know who are in this study. But no, we didn't see much. And again, the advantage of doing these individual interventions is you can power it at the individual level. You don't have to power it at the school or church level. Okay, fat consumption followed more or less the same pattern, and this was a primary outcome, so more important to us. And here again, you see the tailored communication doing the best at long-term follow-up, and the Promotora group doing no better than the off-the-shelf group at the end. So I shouldn't have made fun of that. How to eat less fat. Apparently, it worked okay. Okay, so secretos de la buena vida, training effort. Well, it wasn't a lot. It was we didn't. These were women who were used to volunteering and knew something about health issues. So it wasn't too much. Effectiveness and efficacy, I think it was demonstrated, certainly at least in terms of M1 to M2 for the Promotora group, or even for the longer term. There was a reduction in everything. There's no real policy to back this. I think Texas has a community health advisor, Promotora aspect to your health care here. We don't. The county health departments decide whether to do that. And so is it scalable? I don't really think it is, because this was tailored to individual households. And I think this is where social media could do something that we weren't able to do. We were anticipating some what social media could do, but this is 15 years ago and it wasn't there yet. And there wasn't the digital, there was a digital divide then that's not as big as it is now. Steve?
Are you aware of any significant efforts where promotors have been employed to cover the entire population with certain kinds of messages versus your targeted intervention community? Theoretically, I mean, if there are enough promotoras in the city and there was funding for it, you could visit people individually about certain.
Well, just offhand, I would say that yes, I am aware of those things, but the efforts I'm aware of are more infectious disease outbreaks, where you don't need as much time, you don't need that in-depth exposure. You just say, hey, get a shot. This place is falling apart, we'll see you. And then you move on, or in fire emergencies and things like that. Those are still community health advisors. But again, often those are brief exposures to a person. You want that face-to-face contact. I'll show you an example of that coming up. But for chronic disease, long-term lifestyle change, no. Okay. Recent study, just completed a couple of years ago, Aventuras para Niños, Adventures for Kids, again, focus group derived, where we went in and changed environments in schools, neighborhoods, and homes using Promotoras as our intervention delivery vehicle. Home visits, basic format, Promotora on the right, going through various behavior change for more physical activity and less dietary fat. And the child just fascinated by the whole thing, sitting there.
That was one of your lectures.
That's my best student. All the rest of them are on social media. Stephen mentioned earlier that janitorial staff in schools can be very helpful in terms of knowing what's going on in school and maybe even contributing to interventions. And this is what we found, that the lay staff were most excited about us being there. And we asked the cafeteria staff in this case, these are part-time minimum wage employees, some of them who didn't speak English very well, if at all themselves, what they thought we should do in terms of the environment. And they were able to suggest things that we had not come up with and that the teachers had not come up with. And they were so happy to be asked, because they saw other programs come in, the drug programs and safety programs, all these other things come in. They never get asked for anything. And here we got them centrally involved in the cafeteria intervention. And they came up with this idea, which was start with salad. It was a simple positive reinforcement thing where if a kid go through the lunch line and sit down and rather than throw the salad away immediately, would actually start the entire meal by eating the salad. The cafeteria staff would come in, pop a little sticker on their shirts on a random basis, and that worked really well. We got, didn't last a long time, but it got their attention. But here we had a new challenge. It wasn't just the behavior change challenge at the individual family level. We were talking about advocacy and community change and neighborhood environmental change. And promotoras, we were going to randomly assign them to either the behavior change, community health advising, or advocacy. And 90% of them said, advocacy, once we explained what it was, I ain't going there, I ain't touching that. No. And we either lost them or we let them go back to the family home intervention. That's what they'd signed up for. We're not doing this stuff. So what we needed were promotores who were willing to go to restaurants to talk about menu, portion sizes and menu content, and willing to go to parks and recreation sites to see how accessible they were and how safe they were. And here's just a typical, you've all seen these, a typical inner city San Diego playground that they worked with. Water fountain did not work, graffiti all over the place, restrooms are locked, lights are broken out, and syringes and used condoms in the grass that wasn't mowed. And so no parent in their right mind is going to take their kid to one of these playgrounds. And so here they are, they guilt-tripped a city councilman into sending his aide out, and they kind of rubbed it in his face, but these were special women. They were not our typical. We had to go through trial runs to see if they could do this, and they didn't hesitate a bit. They were not typical. Again, these were very distinct people who really wanted to see these changes and weren't afraid to ask. So, in terms of Aventuras, training effort, well, it wasn't that bad actually. It was, again, it would require a few hours and a booster sessions here and there. But we did not get many dropouts. They all eventually liked their assignments. Efficacy, we did not get, I'll be honest, I didn't expect we would. We did not get obesity change in the environmental change group versus the control group. Effectiveness, well, in some ways, yeah, it was rolled out in a real-world situation. We did get school environmental changes, certainly, and you saw some of them. But we also got park changes after the study was over. But it took much longer to do that. You got 5 years on an R1 or 4, and that's not how this stuff. And I think Andrew and Steve have come up with some better ideas on how to do some of these things. But nevertheless, it takes a long time. Backed by policy, well, yeah, yes and no. I mean, the city has to be interested. The school district has to be interested. Can you do that always? I don't know. Scalability, again, these environmental changes certainly should be scalable, but it's city budgets and county budgets and priorities. So yes and no. So you're getting a little contrast here. Okay, so an international variation, just to take us traveling here for a minute. A lot of the work I did that informed me, I think, as I was working through these in the USA, was in developing countries, in Honduras and Guatemala and Ecuador, and then eventually in Indonesia. This is the late 80s, early 90s, where the USAID-funded project was looking at ways to use health communication to reduce deaths due to diarrhea. This is, at that time, it seems interesting now because that's totally changed, but it was the #1 killer of humans until the 1990s. Dehydration due to diarrhea. And it's pretty well gone now because we got it sort of figured out. Anyway. The trick was oral rehydration. What we found was that Kader comes from the Dutch word for cadre. It's a Maoist idea where you would have health cadres and literacy cadres marching out into the villages. And well, they got rid of the Maoists in Indonesia, but they kept the Kader idea. So they still have these health volunteers. 1 million strong, I think, throughout this heavily populated country. But most of them did what the guy is doing on the right and just do growth monitoring. They put a child on a scale, they record the weight, kind of measure them, write it down on the card, give the card back to the mother. No interaction, whether they're growing okay or not. So that. Our idea then was try to give the Kader a role in actually keeping kids well. So we got a behavioral training approach that we rolled out in Western Java, that's where Jakarta is, and trained Kader throughout the province of Western Java to do actual behavior change with the mothers in their villages, and use behavioral techniques to train the Kader to do so, and gave them the portable supervision they needed. This is pre-text messaging. To be able to go through a fairly complex behavior change with a mom whose kid had diarrhea. Kids get diarrhea all the time, every nation, every country, but they don't need to die from it. And so that's the whole premise of oral rehydration. So here's our messages. We wanted to get Kader to do the right diagnosis so they knew whether to refer a kid or not, and if they didn't refer a kid, at least to keep them healthy at home. And what we did was develop a counseling card, just simply a decision tree, a binary decision tree. They work from left to right to come out a diagnosis, and then the final diagnosis are those different types of diarrhea or dysentery that they have in the right column, far right. And those are on the white card, the diagnostic card. The Kader would be looking at different color codes for each of those. I'll show you here in a second in the Indonesian language for each of those diagnoses. So if they arrive at the diagnosis of dysentery on the top, I can't read much of Indonesian, but then they would go to a card that matched that blue or teal, whatever it is. Light diarrhea would be the second card, et cetera, the green card. And here's what the cards look like. They're pictures, mostly pictures, so they could show them to the mother, mixing water, mixing the liquids, feeding the liquids to the kids. Very heavy on pictures, low on literacy. And breastfeeding, maintaining regular breastfeeding. So you can see, again, the behavior's altered a little bit depending on how severe the kid's case was. In a case of severe diarrhea, get them to the clinic right away, but also continue regular breastfeeding and do the oral rehydration. So here's the training. The guy is a nurse auxiliary in a white uniform, and the Kader, the volunteers, are the people in civilian clothes on the right of that picture. So the physician goes through the steps of the counseling card. And the role play ensues with the two nurse auxiliaries practicing, one being a mother and the other being a Kader, to model the behavior for them. Then they go through a role play where the nurse auxiliary pretends to be the parent of a sick baby. It's a very sick baby. And the Kader then has to show that she knows some of these steps and knows how to work the counseling cards. So it's just 6 cards, one for diagnosis and the rest for counseling. And all they had to do really was match it up. Then they broke out into role play groups of 3. And the nurse auxiliaries and the physician walked around the room to make sure they're doing it right, etc. Mixing this stuff is really difficult. It looks easy, but it doesn't dissolve well. You got to get the quantity right. If you hypersalinate it, you can actually make the kid a lot worse or even kill him. Okay, so Kader, what I was amazed with was the regular training that they were doing. We had 68% accuracy in behavioral tests. We used behavioral observation to test them. We did not use self-report instrument. And the control group did well, 68%, but the intervention group was 83% accuracy in both diagnosis and management. Then we went to the villages with between 1 and 3 months, way out there in the middle of nowhere, and just knocked on doors, found as many moms as we could, and asked them if their child had been sick, did they go to their Kader, and if so, what did the Kader show them? And 97% of the mothers were perfectly accurate in mixing, and if trained by intervention Kader. And again, this is the first time we had seen these mothers. We just put the stuff in front of them, and they could do it. 74%, fairly remarkable in the control group. And that's why, because that secular trend was improving, we see, I think, dehydration as a major cause of death kind of eliminated. Okay, so finally we got a motivational problem with Kader. We couldn't figure out their volunteers, like any of us who have used volunteers, you get a high dropout rate, and retraining, re-recruiting, all of that is very difficult. So we had exceptional, they had over 50% dropout after initial training. Never saw a patient, never walked into a clinic. So what we had to figure out ways to deal with that in a place with very little mass media, but just radio. Roads were bad. How do we get to these people and keep them happy? So developed radio spots, and this was my idea of vicarious reinforcement, where two moms are talking about a child, Chimpluk is a wonderful name of this child. Who is just recovering from diarrhea. And the second mother says, well, yeah, I got this information from the Kader. Isn't that great? And blah, blah, blah. What we're finding out was that, of course, these conversations were heard all the time, but the Kader were never asked or never told that the village appreciated this. So by hearing this on the radio, we got more of a proactive conversation about the issue. So we broadcast, we had asked the Kader, what would it take to keep you motivated to do this? And of course they said money. That's what any of us are going to say. That's a universal thing. And we said, well, you can't do that. They talked about uniforms and things that we did not have the resources for. But finally, they all agreed on one thing we had the resources for, and that was, if somebody would thank me for doing my job, that would be so much more meaningful to me than just the same old, same old. They come in, they don't speak, and blah, blah, blah. So we got these moms to listen how to thank somebody and then actually do it. So we broadcast 2 spots a day for 3 months in an intervention area in a district we had no transportation to, nothing. And then we had a control district 150 kilometers apart that was not in the same radio broadcast area. Okay, so we then sent a research team out, and 94% of the Kader remembered hearing the spots, 64% of the moms. 65% of the moms said that after hearing the spot, they expressed gratitude to the Kader, and that's versus only 13% who had expressed recent gratitude in the control district. 45% had other health-related discussions. Again, almost about a 4-to-1 advantage there. But we were able to record that we got a big jump in, a nice jump in any case, in clinic attendance. So that was actually objective evidence there. So it worked. These counseling cards took off. The government of Indonesia, USAID, and other aid agencies said, yeah, this works. So all in the next few years, they trained using these same cards, 25,000 Kader. So, training effort. Well, it's still a training effort. Might not necessarily have had to be so much. Maybe we could have done it with just giving them the cards or something, we don't know. Efficacy and effectiveness, you bet. If backed by policy, well, they have a Kader policy, yeah, but as long as it's there, yeah. And scalability, well, I think so. Again, it's fun now for me to look back and see 25 years of mortality figures on diarrhea and say, it's kind of a thing of the past, finally. It always shocked my students to know in those days that it was a killer. They had never heard of it. And now it's sort of shoved into the background. So you can kind of compare and contrast the different types of interventions we had and different scalable aspects of them. So finally, heavy drinking reduction campaign. This was fun for me because I was in the Marine Corps, and then I got to go back in it in the late 90s and to develop alcohol reduction campaign. So here's a version of the social ecological model. We didn't call it that in those days, but basically we're trying to go from a lot of drinks a day to just a few drinks a day, using good old infantry language with frontal assaults and artillery strikes and all those sorts of things. Okay, but essentially what we did was we tried to change the information they had, attitudes they had toward heavy drinking. At the same time, we wanted to do something about accessibility, easy access to booze, and to give them some activities that they could engage in other than just getting blitzed every weekend. This was in Hawaii and Okinawa. So intervention procedures, what I did and why this is part of this slideshow is instead of using captains and officers giving talks in front of large audiences and everybody trying to stay awake and all that stuff, I got down to the sergeant and corporal level. Now, if you haven't been in the military, you might not know what all that means, but these are people who are kind of your age, but have one stripe or two stripes more than you do, and so they have some authority. And they see you all the time. So I insisted on this, is that we not use officers or senior enlisted people, but use young NCOs, and those are sergeants and corporals, to deliver this. And they did a fantastic job for the most part, except the ones who got drunk with the people that they were supposed to help. That did happen. Of course, it's going to happen. But that was how we delivered the controlled drinking campaign. Again, relative youth, but some authority. Okay, so there's some of the videos that backed it up. This is the more traditional stuff with Sergeant Major cussing out a junior enlisted man, putting him in the brig or something like that. I don't know what he's doing. That guy's standing tall. Now this is real life. This is Okinawa. A bunch of these guys are ready to go on liberty, and we followed them. This is Friday afternoon, final formation before they're dismissed, and they go back. They go down to the enlisted men's club and get blotto. And these are things we tried to, but they allowed us to make a video of them doing that. Okay, so control group. We had 409 intervention groups, or 409 people in one battalion, and that was one battalion control and 2 battalions intervention. Again, the 2 battalions intervention were in Hawaii and Okinawa. Small decreases in drinks per day. Didn't see an effect by the group. But the 2 distinctions. One is the Hawaii group did lousy versus the Japan group. Second distinction was that the lieutenant colonel and junior officers in charge of the battalion in Hawaii thought the whole thing was a joke. They were just doing it because they were following orders. But they told us, this won't work, we're about drinking, let them go have some fun, who cares, blah, blah, blah. They obviously were not supportive of it, whereas the lieutenant colonel in Okinawa very much so. But what we were finding was that one thing none of them would support was getting more heavy-handed with discipline or reducing access to cheap beer. Beer in PXs is cheaper, and distilled liquors too, cheaper than water. So that they would not touch that. Again, what's the question? My friend says, what's the question? The answer is money. And that was, so their resources for having morale-building activities came from liquor store sales. So they're really pretty sick relationship. No change, and no changes were made in sales, not in hours, not in prices, nothing. So, training effort, it was a lot. These were like 1-week workshops we did with sergeants and corporals. Efficacy, yeah, I think where it was supposed to roll out in a real world situation, it did. Effectiveness, no. We weren't able to show, at least if you compare Japan and Hawaii, to show an impact. If backed by policy, possibly, but I don't think so. And scalability, well, there wasn't really anything to scale because we didn't show any effect. Wanted to publish this, but the United States Navy would not allow me to publish the data. So, where do we go with this? So, community health advisor interventions, agents of change, usually demonstrate efficacy. They have the potential to be effective, but they require a lot of professional time. And this is on us now to figure out how to reduce that and still keep that interpersonal touch there. They have high dropout rates. They'll have occasional error in health messages. They'll answer a question they shouldn't be answering. They'll make it up. They'll forget what they were supposed to say. And there's a decay of skills, so they need retraining even if they stick with the program. But they need to be backed up by advocacy and policy change, I think. Otherwise, from a public health perspective at least, you can always show the effect or efficacy, usually show effectiveness, but backing all those things up and making it sustainable is hard to do. You have to identify appropriate incentives. We got in trouble with the County of San Diego because they have a Promotora program that's just for volunteers, and we were paying them. And we got a phone call and said, what are you doing? You're going to screw up the market, blah, blah, blah. Well, we went back and forth. I don't know if we ever resolved that. But there's a controversy even in the literature among people who do this kind of research, whether these should be paid people or not. What we're trying to do, though, is find community college credit to find these graduation ceremonies and things like that, which is this, to do other things that can serve as incentives. Publicity, that can be really big, a community newsletter or a spot on the radio where you mention people's names. And special thanks to so-and-so for doing this. That really means a lot to people. And I think to us as well, right? So it's, again, they're not unique in that sense. Money, again, controversy. Who's the best health advisor? Well, it's going to be depending on the situation and on the feasibility. So there's a auxiliary nurse in Honduras. On the upper photo, lower right, is a Promotora who lives near the neighborhood in our Secretos nutrition program. And that's lower left. And lower right is a junior high school student getting a home visit from 2 high school students for a smoking prevention campaign. So current research issues, is it effective, and if so, compared to what? And again, I'll go back to my Secretos design. Should we have had a pure control group, or if it's usual care, what does usual care look like? Is it the antithesis of institutionalization? How do you institutionalize a volunteer or an auxiliary program or a paraprofessional program? Is it a true public health approach relating to institutionalization? But in this case, do we have enough reach to really call it a public health program? Can we really do something about incidence and prevalence with this? Okay, so 2 concepts to remember in health communications: frequency and reach. You all know what that is, but frequency is the number of times you hear a message, hopefully from different sources, but the number of times you hear a message, and the reach is the number of people who hear that message. It's pretty simple. How do we balance those? Because you don't have the budget ever to do both of those. Well, it depends on your target. So I call this the population attributable risk approach, where we're trying to move an entire curve toward a lower risk behavior. If you go out and do a community-wide smoking cessation campaign, you're always going to get the, my grandpa drank a pint of whiskey and smoked a carton of cigarettes every hour and lived to be 110 or whatever. And there are those people. But you're saying, well, on the average, you can reduce your risk by such and such, and we can move that curve a little bit to the left. So that requires a much different approach than when you got a high risk reduction approach. And now, an example of that would be when you got kids at a vulnerable age for smoking. When you got young Marines who, for the first time, are away from home and are around a lot of people who drink heavily. Those are high-risk people. So you need a higher frequency and maybe need to sacrifice reach as a function of that. Okay, new directions. Advocacy. I like the idea of using change agents for advocacy. It takes a special type of person, but they do exist. A lot of what I present is Mexican immigrant community, but we have to think about, okay, so how generalizable is this then to other ethnic groups, to multi-generation families, or people who have been here for multiple generations versus people who are fairly recently across economic classes, etc. And other formats. Obviously, how can we take those counseling cards and put them on a cell phone? I think that's doable. But how about some of the more complex chronic disease risk reduction approaches? Can we really can we use that in a text format? And if so, is our intervention group going to be as successful if we just communicate directly with them versus going through a community health advisor? I still bet on the community health advisor that somehow the face-to-face communication, even if it's FaceTime, is going to be more effective. And so here's the bottom line. Here's our Promotoras again from the Aventuras project, and they're receiving a check for $400,000 to clean up that nasty park, which is now completed. I got to get down there and shoot some more pictures of the post. But the city did feel guilty, and they had a little money left over. Okay, that's it. I'm certainly, if anybody has questions or comments, or.
Could you actually Sassy speak up so we can pick it up to the screen?
Yeah, Bill.
John, very nice talk, and appreciate all the perspectives bringing you together. That one column again has been bugging me recently from a physical activity standpoint. That's interventions for sustainability. Scale it and sustain it. I think sustainability is part of the definition of scalability.
Yeah. Yeah.
What pearls can you share about where we should be going to figure out how to translate, even with community health workers here doing the project, even other behavioral interventions? There's just not a lot out there, particularly Deb Salvo just wrote a big paper on it and reviewed all the literature. We don't know how to scale this stuff up to go beyond the people in front of you or the small community that you targeted and then you leave. Can you share a little pearls on where we are?
Well, that's tricky, and that's what we all strive for, obviously. I think we have to continue to focus on and we do in grant reviews sometimes, we say, wait a minute, this is great, but come on, you're not going to go anywhere with a 30-session counseling for weightlifting or something like that. For working age people, it's not going to happen. We got to look at expensiveness. We got to look at other feasibility issues, and then we got to see what health outcome we're pairing these with. We had this discussion in the morning session. Sometimes health behavior is worthy in and of itself. If I contribute to a school offering tastier, or tasteless, I should say, water, clean water, that's cool in our hot climates and all of that, and kids drink more water, that's a good outcome. It doesn't have to impact obesity to be a good outcome. It might impact obesity, but it doesn't have to. So, and that's something that's inexpensive. These water fountains are now becoming ubiquitous, but even when they weren't, they didn't require a lot. So if we could start at some of these levels and look at much larger populations in our outcome analysis, and with the water fountain thing, we don't know how much drinking of water is actually going on, but we can measure easily how much is dispensed, right? Just that alone would be a good way for us to demonstrate scalability if we accept drinking water as a good outcome. Again, if you're going to hold us to the feet to the fire on obesity changes, it's not doable. So I think we got to look at how expensive these things are, how otherwise feasible or not feasible they are. Do I need a 30-session counseling, motivational interview?
DPP or something.
Right. No, it's not. And is this going to, I'll give another example, walking school bus. Great idea, but just the permits you would need, the training you would need, the lawyers that would have to be involved. We tried to roll this out in San Diego schools, and the parents just laughed at us and said, I'm not walking on somebody else's kid to school. I damn sure I'm not walking 10 other people's kids to school. We didn't think through those issues. Again, a great idea, but one that was not going to be scalable, not because of an expense issue, but a feasibility issue. It just had other barriers involved. So I just think I think what we should be doing is funding. There should be like innovation, all that sort of stuff we rank grants on. There should be a section on scalability or something like that, the sustainability and scalability, if you will. But there often is not. So I think we need then in the meantime to do more cost benefit or cost effectiveness evaluations. Andrew.
Thank you for your great talk. I really appreciated your discussion on how obviously an agent could be more effective in sending a text message, that face-to-face influence. And it seems like there's a lot of research to show, right, that social influence is so powerful. But how do you scale it? And I know in our work with Catch, we've tried a lot with a common approach to take a champion, identify
Right.
such champion. And one thing I think we've learned over our years is often that Catch champion is the default, is the PE teacher,
Right.
which isn't always the best. And so
Yep.
I really appreciated your approaches, and just wondering if you could talk a little more, how you identify that person. It seems like that could be, a really important direction for our research. And then the other thing you said that really resonated was, how do we recognize that person?
Yeah.
Because we know we try to do some things with Catch with award ceremonies, but they're not getting. There's not a lot of money to pay Catch champions in schools.
Exactly.
So anyway, those two topics you brought up resonate. I think that more research.
Right.
The last thing is we're learning. I was just out of the school, and they're now using students as part of their wellness team. And how could fifth graders be more effective teachers may be promoting.
Right.
So who's the right role model?
Right.
So anyway, I'm just curious if you're.
Well, the first part of that, Andrew, I think back to the paper I read years and years ago, Larry Green, and he had gone, the reason for him using this word champion, I think, as I recall, is that he had gone back to Bangladesh, which was then East Pakistan, actually, when he worked there, and to see if these community health volunteers in a BRAC program had continued with whatever a TB program or oral rehydration, I'm not sure what it was. And then he traveled back there 20 years later or something. Very cool thing to do. And he then figured out which programs were continuing to run and which were not. And he said it was based on whether they had a champion or not. I mean, it was retrofitted, but it made a lot of sense to me. But it was retrofitted on that observation. So then we started thinking about this in Catch 1. And in TAG, we even expanded this idea, was, okay, who's our champion? Who's going to be our school champion? And so two things. One is, I think we do need research on that, on how these folks are best identified. But I think and I haven't done research on it since the Pawtucket weight loss program. But these people we went up to and asked them to volunteer once we fill out and read these questionnaires, they were flattered that their peers thought so much of them that they would want them to be trained up to do this specific thing. So that helped. The second thing is you've got to limit service time. You can't make these things open-ended. The idea of a champion is someone who gets behind this for a lifetime and blah. That's just not realistic. But if you can do those two things and say, here, we need 10 hours of your time over the next year, and this is because your peers thought, or your students or whoever thought you were the best person for this job, that's a start. Now, again, it needs to be researched, as you're saying. Then how do you give them the recognition? I think what the Kader told us was that they wanted the community to say something. They didn't want an award. They didn't, unless it was a uniform with a bunch of ribbons and stuff on them, which we couldn't afford. But they wanted the community to say thank you. And so a ceremony that we put together that's meaningful, if it's done well, I think those are important. But I think more important is that they want their peers, their students, their administrators to say thank you. They might appreciate their picture in the hallway, in the special parking place or whatever for a month, or, those sorts of, who knows? But I think that the best way to find out is to go to them and say, in general, not to the target person because they're going to be very suspicious, but in general, if you, in your school, how would you keep somebody motivated with that? I think you could come down to those kinds of things.
Hey, John, glad to have you here.
But
Has the California Medicaid program been approached about hiring promotoras, and if so, how are you all managing that in the state, and for what programs?
Well, now I don't know how big it is yet, but we have the clinic navigators, the patient health navigators, and a lot of these fit that role we would have called a Promotora role, and they are funded. Now, exactly how for what program, I'm not totally sure on that one, but they are in our federally qualified health centers. But again, I think the patient navigators, the kind of the wave of the future. I think expanding their role could really increase our impact.
Yeah, and I know that the Office of Minority Health was approached at the time all those patient navigators came online, but they were so busy dealing with the service of affordable care.
Right.
That they couldn't see beyond, using
Absolutely. But again, you're right. It does make administration more complex. And we're looking at expanding their role into prevention activities. Unfortunately, in the meantime, I think it's only for treatment of illness. I don't think we have anything in prevention.
No, we don't.
You don't
Not
either.
that I know of.
That would be neat to see that expanded. But then the supervision gets even more complex because what's your marker then for doing your job? You know.
Well, I know in the state of Texas, back around the 74th or 76th legislative session, it was proposed that we seek an 1115 waiver to support promotoras here in the state who were certified. And we made a run at it, but didn't quite get to the summit, so to speak, to make that work. But there is a consistent effort to try to still do that in this state, given the amount of money that's available through the Medicaid.
Right, right. No, and Texas is a leader in that. I must say, they get it. Hearing none.
Thank you.
All right, thanks.